My name is Pablo Sanchez, and I will be presenting on the 2021 International Web-Based Neurosurgery Congress the e-poster called Unusual Subdural Location of a Metastatic Small Cell Neuroendocrine Carcinoma, a Case Report. A 77-year-old patient was admitted due to sudden altered mental status, global headache, and right motor and sensitive syndrome. On neurologic examination, we found a slight right hemiparesis, hypoesthesia, hyperreflexia, and Babinski sign. We found an extraaxial left frontoparietal lesion of mixed densities, classifying it as a chronic subdural hematoma with signs of acute bleeding accompanied by local mass effect with compression of the neighboring parenchyma and right sulfosine herniation. Further examination with contrasted MRI was urged due to frontal lobe vasogenic edema not explained by blood collection. We found a neoplastic lesion with infiltrative appearance in subdural location in the left hemispheric frontoparietal convexity, accompanied by a significant mass effect with incipient leptomeningeal infiltration and vasogenic edema in the frontal lobe, causing incipient right unilateral hydrocephalus and left uncal and right sulfosine herniation. Surgical management was prompt with a small left parietal convexity craniotomy. During surgery, a diffuse infiltrative neoplastic lesion of subdural distribution with pearly appearance, highly vascularized and associated with a chronic subdural hematoma was found. Bone scintigraphy was performed, finding an abnormal increase in uptake in the left frontoparietal region, the sphenoid bone, the right anterior costal arc, vertebral body T10 and T12. Microscopic studies demonstrated pachymeningeal and cortical involvement due to a small cell neuroendocrine carcinoma metastasis, classified as a WHO grade 3, with a proliferation index quantified at 95 to 100%. After the first surgery, the patient presented complete neurologic recovery. A second emergent surgery was required due to acute neurologic deterioration because of a new subdural effusion. No primary origin was found, and no complementary oncologic treatment was offered because of poor short-term prognosis. The patient died 1 month after diagnosis. Neuroendocrine tumors are highly varied and heterogeneous neoplastic lesions. They refer to lesions with dense central granules similar to serotoninergic neurons which store monoamines. They are synthesized in the central nervous system, respiratory tract, larynx, gastric tract, thyroid, skin, breast, and urogenital. The incidence oscillates from 4.4 cases per 100,000 people. Most of the neuroendocrine tumors arise from gastrointestinal lesions, being this the most frequent primary site, followed by lung origin. Approximately 20% of cases present metastasis at initial diagnosis, and of this, 1.5 to 5% present intracranial metastasis, most of them being secondary to lung origin. The problem with this type of tumors is the short survival whether or not treatment is done, being it gross total resection, radiation therapy, or observation. Overall, there is no significant difference in the mean survival time in patients with metastasis treated with radiotherapy, surgery, and radiotherapy or observation. There are some proposals that in patients with brain metastasis secondary to pulmonary origin, the best approach should be surgery followed by holocranial radiotherapy. Nonetheless, data are lacking. In general, if there is a single lesion, gross total resection should be prompt. If there are multiple lesions, chemotherapy should be done. Metastatic disease is the major prognostic factor in neuroendocrine neoplasms, in addition to its degree of differentiation and speed of proliferation. In general, for brain metastasis, it's primary, it's pulmonary. Time for appearance of brain metastasis are 5 months to 12 months. Because of this, routine use of brain imaging is not recommended. Risk factors for poor prognosis are high proliferation index superior to 55% and brain metastasis. To the author's knowledge, there is no case report of subdural small neuroendocrine metastasis in the literature. Awareness of metastatic lesions as differential diagnosis in subdural space occupying lesions simulating conventional subdural hematomas must be prompt in order to establish a rapid treatment. Thank you.